Hello everyone. Today I will narrate another previous topic of medicine, COPD. I am making this video so that you can easily revise the medicine within one day or two. For example, you can revise the hematology within 1 hour. You can check my playlist. So let's start. COPD is an obstructive lung disease just like asthma. So there will be increased FRC, RV and TLC and decreased FEV1, FBC and FBC ratio. Also VQ mismatch. COPD is mainly two types: chronic bronchitis or blue botters and emphysema or pink puffers. Chronic bronchitis, there is wheezing, crackle, cyanosis, dyspnea, CO2 retention, secondary polycythemia. And in pathology, there is hypertrophy and hyperplasia of the mucous secreting glands. The question asked is rate index, which is more than 0.4. The DLCO may be normal here, but if the question asks DLCO in COPD, it is decreased. In chronic bronchitis, it may be normal, but in emphysema, it is obviously decreased. Overall, in COPD, it is decreased. Diagnostic criteria for chronic bronchitis: productive cough for more than equal to 3 months in a year for more than 2 consecutive years. In case of emphysema, there is barrel-shaped chest, exhalation is prolonged and or through pursed lips. It is mainly four types, but we will discuss the two types, centriaquinar and panaquinar. In centriaquinar, it affects the respiratory bronchioles while sparing the distal alveoli, whereas in panaquinar, it affects respiratory bronchiole also with alveoli. There is a video game called CSGO. Remember the mnemonic CS. Centriaquinar for smoking, and also smoking rise up. So centriaquinar will involve the upper lobes, and in case of panaquinar, it frequently involves the lower lobe. There is decreased recoil, increased compliance, decreased LCO, imbalance of proteases and antiproteases. In X-ray, there will be increased epidiameter, flattened diaphragm, increased lung field lucency, and chronic inflammation mediated by CD8 plus T cell, neutrophil and macrophages. Let's come to the one-liners. Cigarette smoking is the most common cause of COPD. Major site of increased resistance in most individuals with COPD is small airways, which is less than equal to 2 mm diameter. Clubbing is not a sign of COPD. If you see clubbing in a known case of COPD patient, think of lung cancer in agent patient. Also, there is no rise of post-bronchodilator FEV1 more than 12% on COPD. In case of asthma, there is rise of post-bronchodilator FEV1. There is also rise of DLCO in asthma. Body plethysmography is the best indication to measure lung volume in an emphysematous patient with blood lesion as seen in X-ray. DLCO is decreased in COPD but is normal on increase in asthma. Severity of COPD assessed by Global Initiative for Lung Disease, GOLD criteria. It is very common. There is 4 stages: 1, 2, 3, 4. Mild, moderate, severe and very severe. The FEV1 and FBC ratio are same in all cases. The FEV1 of predicted is determined in the stage of the COPD. 80%, more than equal to 80%, 50 to 80%, 30 to 50%, less than 30%. It was asked in NEET 2020 that which is the very severe type of COPD. The FEV1 is less than 30% with FEV1 and FBC less than 0.7. The severity of dyspnea can be assessed using modified MRC dyspnea scale or CAT scale or CAT score. Here it was severity of COPD, here is severity of dyspnea. MMRC scale: 0 is breathlessness only with strenuous exercise, 1 is when hurrying on a level or walking up a hill, 2 is walking slower than peers or walking on a level, 3 is stop for breathing after walking 100 meters or few minutes, 4 is breathlessness at rest. 0 and 1 are considered less symptoms, 2, 3, 4 are considered more symptoms. So also in GOLD 2020 guideline, there are 4 types of COPD patient: A, B, C, D. It was based on frequency of exacerbation and severity of dyspnea. The A and B has the same frequency of exacerbation, 0 or 1, not leading to hospitalization, that is risk. A and B are differentiated using the MMRC or CAT score, that means the severity of symptom. Less symptom, there is E, and more symptom, that is B. 0 1 MRC score is A, or more than equal to 2 is here is B. Same for CAT score, less than 10 is A, more than equal to 10 is B. Also in C and D, the frequency are increased more than equal to 2 or more than equal to 1, leading to hospitalization. There is more risks. Again, C and D are differentiated using the MMRC scale and CAT score. Less symptom are C, just like A, and more symptom are D, just like B. And in treatment, in A patients, there is any short or long acting inert bronchodilator. In B, there is LAMA or LABA. In C, there is LAMA. In D, there is LAMA or LAMA plus LABA or LABA plus ICS. And coming to treatment part, smoking cessation, anticholinergic agent, beta agonist, methylxanthine, phosphodiesterase inhibitor, roflumilast. It is asked, remember the name, when FEV1 is less than 50%. Antibiotic, N-acetylcysteine, oxygen therapy. And surgical treatment include lung volume reduction surgery or lung transplantation. Management of acute exacerbation of COPD. The initial management consists of 4: bronchodilator, which is inhaled beta agonist or muscarinic antagonist, antibiotic, low flow humidified oxygen, and non-invasive positive pair ventilation. The target SpO2 should be 88 to 92% or PaO2 60 to 70 mm Hg. NIPPV fails, then invasive positive pair ventilation may be provided, and glucocorticoid is used only in exacerbation. It is contraindicated in long-term management. It was asked in NEET 2020, the initial management of the acute exacerbation of the COPD. Remember the 4 points. Contraindication of NIPPV: cardiovascular instability, impair mental stature or inability to cooperate, copious secretion or the inability to clear secretion, craniofacial abnormality, and trauma precluding effective fitting of the marks. This completes the topic COPD. Now you can solve the previous question from COPD or the Maroc Weaving question from COPD. See you in next video with another previous topic from respiratory system.